You have a patient with mild to moderate ulcerative colitis sitting right there in your exam room.
Right. An incredibly common scenario for most of us.
Yeah, I mean, I'm a clinical pharmacist who sees this constantly. And as a specialized IBD gastroenterologist, I know you do too. So the patient has been doing relatively well on their standard maintenance dose of oral mesalamine.
But now they're actively flaring.
Exactly. The symptoms are creeping back up, their quality of life is dipping, and, the urgency and tenesmus are returning.
And they are looking directly at you, the clinician, for the next move.
Right. And it's a high-pressure situation. You want to give them immediate, effective relief.
Absolutely. The stakes for that individual's daily life are just incredibly high.
And the instinct, the almost overwhelming reflex for so many of us in the clinic is to simply write a prescription to increase the oral mesalamine dose.
Because it feels incredibly logical, doesn't it?
It really does. Okay, let's unpack this. Think about how you might instinctively handle a poor signal on a car radio.
Oh, I like that analogy.
Yeah, if there's static or you just can't hear the music clearly over the road noise, your immediate reflex is to reach over and turn up the volume.
Right, you just crank it up.
Exactly. So in the clinic, if the current dose of pills isn't working to suppress the inflammation, giving more pills seems like most straightforward fix to just, drown out the flare.
And we also have to factor in human nature here.
Oh, for sure. Patients overwhelmingly prefer swallowing a few extra pills to dealing with the alternative.
Right. I mean, nobody actively wants to use suppositories or enemas.
No, they absolutely do not.
So it's the path of least resistance. It's easier for the clinician who has, maybe exactly 5 minutes left in the appointment?
Barely that, usually.
Right. And it's vastly preferred by the patient who just wants to go home with a simple, clean solution.
But balancing effectiveness and tolerability in these mild to moderate UC flares is, well, it's not as straightforward as just upping the dose.
No, it really isn't.
No.
And our mission for this deep dive today is to thoroughly challenge this exact instinct.
Because we need to explore why this common prescribing habit, relying solely on oral escalation, might actually be doing your patients a massive disservice.
Right. Let's move from that natural prescribing instinct to the physiological reality of the gut during a flare.
Yeah, because if an oral formulation works well enough to maintain a baseline of remission for months, why does escalating that exact same oral medication fail to put out the fire of an acute flare?
What's fascinating here is the sheer mechanics of mucosal absorption and pharmacokinetics during a flare.
Right, break that down for us.
So oral mesalamine relies on a descending, highly orchestrated delivery mechanism. Whether you're prescribing a pH-dependent coated pill or a time-dependent multi-matrix formulation.
It assumes a normal GI environment.
Exactly. It assumes a stable, relatively normal gastrointestinal tract. You swallow the pill, it travels through the entire GI tract, and the active 5-ASA ingredient is released to eventually bathe the colon.
But during an active flare, the colon's physiology is just an absolute chaos.
Total chaos. Transit times are drastically accelerated by diarrhea and altered motility.
The luminal pH drops too, right?
Yes, due to changes in the microbiome and the inflammatory exudate.
So the drug simply doesn't have the time or the optimal environment to deploy properly.
Exactly. And furthermore, the mucosa itself is laden with crypt abscesses, ulcerations, and a really heavy inflammatory burden.
So it loses its standard absorptive surface area.
Right. Relying entirely on this top-down systemic approach often misses the mark. It fails to deliver targeted, high-concentration therapy precisely where the inflammation is most dense.
Especially when the disease extends distally into the left colon and rectum.
Exactly.
So what does this all mean? I like to think of it like treating a tough set-in stain on a piece of clothing.
Okay, I can see where you're going with this.
Yeah, you don't just pour extra liquid detergent into the main washing machine cycle and hope for the best. That's your broad oral therapy.
Right, it dilutes the effect.
Exactly. To get the stain out, you have to also apply a direct spot treatment right onto the stain itself before you run the wash.
That is a highly accurate clinical comparison.
Hitting the problem from both sides. Because just increasing the systemic volume of mesalamine diffuses the resource.
Right. A massive amount of the active ingredient is wasted or washed out before it ever reaches that distal tissue that is actively ulcerating.
So escalating the oral medication alone consistently fails to provide the best symptom control.
Or endoscopic remission rates, yeah. Because you simply aren't maximizing the intraluminal concentration of the drug exactly where it's needed most.
You're just increasing systemic exposure.
Right, while potentially starving the localized flare of the concentrated 5-ASA intervention, it desperately needs to initiate mucosal healing.
But wait, let me play devil's advocate here for a second.
Go for it.
Because you and I both know we have to factor in the reality of outpatient compliance.
Oh, adherence is the elephant in the room.
Definitely. We know, objectively, that patients strongly dislike topical therapies. Suppositories and enemas are physically uncomfortable.
They're highly inconvenient to use.
And frankly, they carry a significant psychological stigma. Plus, they can be messy.
And if a patient is experiencing severe urgency and tenesmus, holding an enema in place feels virtually impossible to them.
Right. So isn't an escalated oral dose, even if we accept that it's theoretically slightly less targeted, isn't that still clinically superior to prescribing a highly effective topical therapy that the patient is simply going to leave sitting untouched in their refrigerator?
It is a deeply valid concern. I mean, patient adherence is a major, undeniable part of the clinical puzzle.
You can't ignore the human element.
Exactly. Ignoring the human element of prescribing is a recipe for failure. However, and this is a big, however, prioritizing a slightly easier route of administration over optimal disease control is a dangerous clinical trap. Well, when you compromise on efficacy right out of the gate, just to avoid a potentially uncomfortable conversation about rectal therapies, you often inadvertently lead your patients right into prolonged flares.
And we know a prolonged flare is not just a temporary nuisance.
No, it have compounding structural consequences.
Right, like extended mucosal damage.
Precisely. It means worsened daily symptoms, an elevated risk of developing pseudopolyps, and a higher risk of long-term complications like strictures.
Or even colorectal dysplasia down the line.
Exactly. The clinical goal isn't merely to prescribe something the patient will successfully swallow.
Right. The goal is to induce clinical and endoscopic remission as swiftly and completely as possible to preserve the integrity of the colon.
Well said.
Okay, so what does this mean for the clinician sitting at the desk writing the prescription today?
Right. Practical application.
Yeah. If cranking up the oral dose alone isn't the magic bullet and might actually be prolonging the disease state, what should your immediate reflex be?
The universally preferred starting point, the strategy that should be the absolute new default in your clinic, is initiating combination therapy.
So oral plus topical together.
Yes. Keep the patient on their baseline oral mesalamine and simultaneously add topical mesalamine to aggressively induce remission.
You are hitting the inflammation from both ends at the exact same time.
Yes, and the clinical benefits of this dual approach are incredibly robust in the data.
Especially when the disease involves the left side of the colon or is more extensive, right?
Exactly. By combining the descending delivery of the oral formulation with the ascending direct mucosal application of the topical formulation, you drastically improve symptom control.
And the remission rates are much better.
Far more consistent and achieved much faster than just throwing more oral medication in the problem.
If we connect this to the bigger picture...
Right. If we connect this to the bigger picture of disease management, dual-targeted therapy reduces the overall inflammatory burden much more efficiently.
Because you're bathing the mucosa in the active drug from two different directions.
Ensuring high tissue concentrations exactly where the disease is tearing down the cellular architecture.
But here is the truly compelling part for clinical practice, which I think addresses my earlier devil's advocate point about compliance.
Right.
The data clearly shows that this combination therapy achieves these superior remission rates without increasing treatment discontinuation due to adverse effects.
That's a massive point to highlight.
Because usually in medicine, when we double up on therapies or add a completely new vector of treatment, we automatically brace ourselves for a spike in side effects.
Absolutely. If you combine two blood pressure medications, you expect more hypotension.
We're conditioned to expect patients to drop off therapy when we increase the pharmaceutical load.
Right. You're trained to expect that physiological trade-off. But because topical mesalamine is minimally absorbed into the systemic circulation,
it acts almost entirely locally.
Exactly.
Yeah.
It acts locally on the mucosal surface. It binds directly to the epithelial receptors to inhibit inflammatory pathways right at the site of contact.
So you get the targeted high-dose efficacy without adding to the systemic toxicity profile.
Exactly. As a clinician, you can be incredibly confident in this approach. It shouldn't be an afterthought.
It should be the standard, unquestioned first move for induction of remission in these outpatient flares.
Absolutely.
All right, but let's live in the real world of clinical practice for a minute.
It's usually a bit messier than the guidelines.
Way messier. Medical algorithms are clean, but human biology is messy. So we have a solid default strategy. Combination therapy is the gold standard.
Right.
But clinical practice dictates that no single rule applies to every single human body. So when do you need to pump the brakes?
That's a great question.
When does a clinician look at the specific patient in front of them, review their history, and decide to pivot away from combination therapy and break the rules?
Knowing when to deviate from the default algorithm is really what separates competent clinicians from exceptional ones.
So what are the specific patient factors that change the approach?
Well, the first major factor to consider is prior corticosteroid use, or exceptionally high disease activity right out of the gate.
Okay.
If a patient falls into this category, and for whatever reason topical therapies aren't tolerated or are strictly contraindicated due to the severity of their current state,
Then what?
then, and only then, it is reasonable to escalate the oral mesalamine up to the maximum effective dose.
Okay, so the oral escalation is the recognized backup plan. It's like a valid audible, to call it the line of scrimmage, but it's not the primary offensive play you design the game around.
Precisely. It is a secondary option.
Yeah.
Another major factor that demands a pivot is genuine topical intolerance.
Right, local irritation or just absolute refusal.
Exactly. If a patient earnestly tries the suppository or the enema and experiences severe local irritation, or if their barriers to adherence are absolutely insurmountable despite your best counseling,
You have to pivot.
you do. A theoretically perfect treatment algorithm is entirely useless if the patient physically refuses to execute it.
In those cases, oral dose escalation alone becomes the safer bet simply to maintain some baseline level of therapeutic adherence.
Exactly.
Here's where it gets really interesting. How much does patient adherence and physical sensitivity actually dictate our algorithms?
It dictates them heavily.
Because we have the hard clinical evidence telling us exactly what physically heals the mucosa the fastest, but we are treating complex, anxious human beings, not textbooks.
Right. We practice patient-centered care, not disease-centered care. You have to navigate the tension between prescribing the most clinically effective treatment and prescribing the treatment the patient will actually use.
That makes total sense. What about disease location?
Oh, that's critical. If you've recently scoped a patient and confirmed that the disease is limited strictly to the rectum or the very distal colon,
Proctitis.
yes, ulcerative proctitis,
Yeah.
you might not need to manipulate the oral therapy at all for induction.
Topical therapy alone might be enough.
Topical therapy alone, or topical combined with just their standard non-escalated oral maintenance dose, may be entirely sufficient.
Because there is zero clinical benefit to increasing a systemic whole gut therapy if the inflammation is isolated to the final few centimeters of the colon.
Exactly. Why systemicize a purely local problem?
Right. It unnecessarily exposes the patient to systemic processing for a localized issue.
Exactly. And finally, you have to look closely at systemic vulnerabilities, like renal impairment.
Oh, right. Mesalamine is primarily excreted through the kidneys.
Yes. And while significant nephrotoxicity like interstitial nephritis is relatively rare, it is a known documented risk.
So in patients with compromised renal function, you might need to avoid oral dose escalation entirely.
Precisely, to minimize harm and protect their kidneys. Similarly, consider patients with severe anorectal sensitivity.
Like active perianal disease or strictures.
Right. Active fissures, significant pelvic floor dysfunction. They might experience immense physical trauma or intense pain with the insertion of topical therapies.
You definitely have to avoid topicals in those scenarios.
Absolutely. To reduce adverse effects and prevent creating a traumatic clinical experience that shatters their trust in you as their provider.
This is exactly why the art of medicine is just as vital as the science of medicine.
Completely agree.
Understanding what the data says to do and knowing exactly when to pivot based on the unique anatomical realities of the patient is half the battle.
But the other half is avoiding the subtle clinical traps that can derail the entire treatment plan.
Let's talk about those pitfalls. What are the major don'ts that clinicians need to watch out for?
Well, there are several critical pitfalls. We've thoroughly discussed the primary one. Don't assume oral dose escalation alone is sufficient without at least thoroughly considering topical therapy.
Right.
But another massive pitfall is confusing induction strategies with maintenance strategies.
Ah, so keeping the aggressive dual-targeted therapy going long after the mucosal fire is completely extinguished.
Exactly. The strategies we're discussing today, combination therapy for active flares, are induction strategies.
Acute aggressive interventions.
Yes. Designed specifically to put out the inflammatory fire. You must not apply these aggressive induction dosing strategies to long-term maintenance therapy decisions once the patient is successfully in clinical and endoscopic remission.
Because long-term maintenance often requires systematically stepping down the therapy.
Right. Perhaps withdrawing the topical agent or returning to a baseline oral dose.
To minimize the daily pharmacological burden on the patient while sustaining that hard-won remission.
Exactly. That distinction between induction and maintenance is crucial for long-term patient quality of life.
What else catches clinicians off guard when managing these patients?
Clinical context is everything. You must never extend these specific outpatient strategies to severe or hospitalized cases.
Because a hospitalized patient with severe UC is in a completely different physiological risk category.
Entirely different. Their mucosal barrier is severely compromised. They require rapid, potent interventions.
Like intravenous corticosteroids or advanced biologic therapies.
Right. Applying a mild to moderate mesalamine algorithm to a severe acute flare is not just ineffective, it's clinically dangerous.
It delays the escalation to appropriate rescue therapies and increases the risk of colectomy.
This raises an important question, though.
What's that?
How often does that actually happen in practice?
I mean, protocol creep, where a specific strategy works beautifully and safely for mild cases in the outpatient clinic, so a provider accidentally applies it to a severe case.
Just because they are comfortable with the medication safety profile.
Yeah.
It happens much more often than any of us would like to admit, particularly in busy multidisciplinary practices.
Right, or when cross-covering patients on a weekend.
Exactly. When clinicians get comfortable with the high safety profile of a medication like 5-ASA, they tend to stretch its clinical indications beyond what the evidence supports.
That's why you have to draw hard clinical lines.
Another essential pitfall to avoid: don't ignore adherence or tolerability issues with topical formulations.
Don't just hand the patient the prescription for the enema. Check the box in the EMR and assume they're using it.
You have to ask them directly at the follow-up. Are you actually able to use the enema? Are you able to retain it?
And if they say no, adjust the plan immediately.
Right. It requires having those highly specific, sometimes uncomfortable conversations about their daily bathroom habits.
You also mentioned formulation differences earlier.
Right. Don't rely on dosing frequency or minor pharmaceutical formulation differences as your primary drivers of clinical efficacy.
Whether the pill is taken once a day or split into 3 times a day matters less than the total daily dose.
Exactly. And critically, avoid escalating oral doses beyond standard effective ranges without clear clinical justification.
More oral medication isn't always better.
No, sometimes pushing the dose higher is just more toxic to the kidneys without offering a single percentage point of additional mucosal healing.
Let me zero in on something you touched on regarding side effects. You mentioned the importance of not withholding effective combination therapy due to unfounded concerns about adverse events. Are we, as clinicians, sometimes more afraid of the side effects than the evidence actually warrants?
The clinical data strongly suggests the answer is yes.
So we might be gatekeeping the most effective combination therapies simply because prescribing 2 medications feels inherently riskier than one?
Exactly. Because oral medications feel safer and more familiar to prescribe in a general GI setting, some clinicians hesitate to prescribe the dual therapy.
They fear they're overloading the patient system.
Right. But the evidence clearly shows that if the patient physically tolerates the topical application, the combination therapy does not significantly increase adverse events.
Wow.
Yeah. If you withhold combination therapy based on an unfounded fear of systemic side effects, you are effectively gatekeeping remission.
You're allowing the mucosal fire to burn longer than it needs to, which harms the patient's long-term prognosis.
Exactly.
Well, we've covered a massive amount of clinical ground today, from pharmacokinetics to behavioral psychology. Let's synthesize all of this.
Let's do it.
If a clinician listening takes away just one golden, actionable rule for their practice tomorrow morning, what is it?
The golden rule is this: for mild to moderate ulcerative colitis flares in the outpatient setting, start combination oral plus topical mesalamine to maximize remission.
Hit the inflammation systemically from the top down and locally from the bottom up.
Exactly. Escalate the oral dose alone only when topical therapy isn't tolerated or if there's prior corticosteroid use.
Always tailoring to disease extent and individual patient
Right.
factors.
It's about actively breaking that automatic ingrained reflex to just write a prescription for a higher milligram pill.
Taking the extra 2 minutes to explain to the patient why the targeted topical therapy is the absolute key to putting out the fire in their colon.
It requires a fundamental shift in how you communicate the treatment plan.
But as we wrap up today, I want to leave you with a thought to ponder that stretches a bit beyond today's current clinical guidelines.
Oh, I'm intrigued.
We've spent a lot of time discussing the tension between clinical efficacy and patient adherence, specifically how much patients dislike rectal therapies.
It's the major friction point. It's precisely where pharmaceutical science collides with human behavior.
So consider this. What if the next major breakthrough in inflammatory bowel disease isn't about discovering completely novel pharmaceutical compounds?
Not a massively expensive new biologic.
No. What if the real revolution is simply about radically redesigning the delivery mechanisms of these topical therapies?
Oh, wow.
Imagine a near future where we create formulations like advanced nanogels, localized smart release foams, or bioadhesive delivery systems that are so seamless and comfortable to administer that patient adherence finally aligns perfectly with clinical efficacy.
That would be incredible. If we can remove the physical discomfort and psychological friction of that targeted distal delivery, we completely change the landscape of the disease.
You wouldn't have to compromise between what heals the mucosa and what the patient is willing to accept.
Because at the end of the day, as clinicians, you want that precision back.
You want the gastroenterology clinic to feel just a little bit more like setting a broken bone. Clean, targeted, highly effective, and definitively fixed.